All right. Hey, baby. All right. Make sure this goes past your muzzle. I know. 5 honey, take appointments. All right. And I need to hurry up.
For Dr. Willis.
One second. Get coffee with it. That's my phone. Let's see. Just sure that I can get 2 fingers. Let's get some color all the way around. It's not too tight, but it's tight enough to keep him from licking at his CCR repair. How you doing? This is Joseph Collier, student ID E3127154, and this is Yogi Phillips. This is going to be my patient for today. He is a drop-off for a ACTH stem to check to see if he has Cushing's. This patient has recently become PUPD, which means he's drinking a lot of water and urinating more. So one of the things we want to test is his cortisol levels to make sure that he does not have Cushing's disease. He's a drop-off. He came actually before I came this morning, so I did not have a chance to speak to the owner, but based on his drop-off form, fed his chicken-based kibble and a can of wet food this morning at 8 a.m. He is currently taking Apoquil for his allergies, and so now we're checking to make sure that his PUPD is not because he has issues with his cortisol levels. We also ran a urinalysis on him, which was a free catch from this morning. What I'm going to do now is go ahead and acquire his vitals. He was weighed when he came in this morning by client service representatives, but I will show you how we obtain a weight from a patient. So he was 26.8 pounds today. So I'm going to start from the head of my patient and work my way to the back when getting his vitals. So we'll start with the mucous membrane and capillary refills. So I'm going to lift up his top lip on the maxillary area, and I'm going to press the gum line just above his canine. So right now his mucous membrane colors are nice and pink, although there is some dark colored pigment to it. They're nice and healthy and pink. So this gives me an indicator that he probably has good adequate blood pressure, that his oxygen saturation is within normal limits, and the color returns within 2 seconds, which is good as well. Checking to make sure that his gum colors aren't abnormally colored, pale, is an indicator that the patient might have some underlying anemia or blood loss somewhere. If they are blue or cyanotic, that could mean that he is in some sort of respiratory distress, or that he is not oxygenating well, so his mucous membrane colors can become blue. If they are yellow, that could be an indicator, or icteric, that could be an indicator of something else going on potentially with his liver or increased bilirubin. So knowing that his gum colors are nice and pink and the color returns within 2 seconds, I'm going to write that down on his travel sheet. The travel sheet travels with the patient, so it stays with them from the beginning to the end. The pink and less than 2 seconds. Now he's actually actively panting, so to get his respiratory rate, I will do that when the doctor comes, and we'll exculpate the lungs and the heart together, and hopefully he will not be panting at that point. To check his pulses, I'm going to go ahead and feel for his femoral pulse. I'm going to take my index and my pointer finger, and I'm going to place them right on the medial aspect of his femur, in between the muscles, and feel that vessel, the pulse right there. And I'm going to count for 15 seconds to see how many times I get an actual pulse or a push on my fingers. And then I'm going to multiply that number by 4, and that will give me how many beats in 60 seconds. So, I'll check that one more time. So I got 18 times 4, 2, 8. That's a little low. I'll take it one more time. All right, so I got 26. So 26 times 4 is 24. So it's like 104. So I got 104 for his pulse. And let me check his temperature. So I'm going to use a pediatric quick thermometer and Sterilube that we only use for thermometers. I'll turn it on, wait for it to measure a low temperature, and then stick this directly in rectally. All right, the temperature is 101.5, which is within normal limits. And all right, he was panting. All right, and that is how you acquire your vitals on a patient. Usually done, the first thing that's done when they come into the hospital. Thank you. All right, Joseph Collier, student ID E3127154, and I'm going to go over ausculting the heart and lungs on this patient. She is a post-op pyometra who is waking up from sedation or from anesthesia. So I'm just going to listen to her heart and lungs post-operatively to make sure I don't hear any signs of a murmur or any regurgitation or any noise, any crackles in the lungs. Anesthesia went pretty unremarkable. There was no regurgitation, no vomiting, and no possible chance of aspiration. So I'm going to start. I'm going to start on the left side, and I'm going to count up to the 7th rib space. I'm going to listen for her pulmonary valve. Listen to her aortic valve. And then I'm going to check her mitral valve. Then from this side, I'm going to listen to where her semilunar valve is. No obvious signs of murmur or potential regurgitation. So I'm going to listen to her lungs. And the other side of her lungs. All right. This patient sounds great for a postoperative patient. Her rate's a little slow, but she's still waking up about 116 beats per minute. So I'm going to work on getting her up so she can go home. Thank you. All right, for Ms. Bashford, we're going to start off by getting her weight. There we go. We'll take it. 7.47. Ooh. Just compare it in the middle of the scale. I know. 7.54. You still lost weight.
Man.
Yeah, you're trying to climb me. Get your old lady sharp nails. Right. Let's start. Go for front. You see you? Alright. Take less than 2 seconds. Let's see. I'm providing like a light scruff. I'm trying to climb like a tree.
Right. So this is on methimazole and prednisolone.
Yes, sir.
And hi.
That's all right. Respiratory rate. Don't grab me.
So I would say running 17 legs using a T4 will probably be what we need.
Okay. 4. 2 seconds. Let's see if I can get.
He said that she had Friskies food before, but she didn't like it, and he recently started her back on it, but that was a while ago.
Alright, okay.
Weight wise, have we lost any weight?
She's lost some weight. She was 8.6 pounds. She's like 7.5.
Got it.
It's all his fault.
Oh. What's he doing to you?
Alright, 101.3. So I need to change the blood work up some. Okay. All right, let me see if I can get do a jug stick on Miss Ruby. Down here. Include the thoracic inlet.
Ooh, so the only one I'm trusting.
Yeah, we're just only shepherd and there's something nice.
Yeah, okay. You're such a well-trained girl.
There's a chick, yeah. That should be over here. What?
You are putting all of your weight on my leg.
Nervous.
She is a nervous girl. You're okay. It's okay. Good girl. Good girl. You're such a good girl of your life. No.
You're leaning away from me. Alright, that should be enough.
She said, I know what I'm doing.
They're right there, and then you kept moving away. Alright, that'll work. So, that should work. Let's see if we can do it. Baby. Okay.
My fingers out the way. Can you see?
Hmm?
Oh no. Oh no. Oh no.
Long fast. I want you to stress out. I know it, bug.
You're doing so good.
Hold that up right there. Alright. So, go ahead and do the purple tube first. Alright, that a few times. Go ahead and put 8. That second calico has been absolutely perfect. Can't complain. And I'm getting a photo. Alright. She can go on back. I know, Mama.
You want me?
Alright, so let's do this lateral saphenous. We get blood for a heartworm test. There we go. Let's get blood going in my syringe. I guess not the way. I know, I'm done, baby dog. Alright, let's run your 40X to make sure you don't have heartworms. Since you're not on drugs. Alright, we're going to do a medial saphenous stick on this kid. So first I'm going to spray a little alcohol to see if I can get the vein to stand up.
Move the alcohol bottle.
In the video.
Yes.
Alright, now I'm going to use a butterfly or wing infusion set for the blood draw. Just because it gives me a little bit more control. And I don't want to damage the vessel so much.
You're okay.
Alright.
No.
Any stuff was her and you'd be a dog.
No.
And occasionally I have to release pressure just to make sure that I'm not collapsing my vessel. I know, you're on the roll again. It's okay, man. Close your little crazy looking eyes. Yeah, it kind of looks like a Sphinx kitty in the
But that's
face.
what I was thinking. Or a
But you're-
Siamese.
You're
Could they have
definitely,
the
yeah,
chinky?
Siamese too. But you're definitely a great tabby.
Giving very much Asian. And what's crazy,
He's confused.
the owners kind of look Asian or
Alright.
Korean.
You can stop that. Alright, I've got my blood.
Just stop.
He's done. Alright, kitty.
I
You
just
get
need to
go
hold it. That's it. Don't flick your tail at me.
He's done with us.
All I'm doing is holding.
Doesn't like it. We talked about his eyes are extra cheeky and he might have entropion.
Okay. You see? You're good. We're good. You're not escaping though.
What's the name
Brock.
of him?
BROCK.
Alright. Go ahead and get his
Nope.
anesthetic blood. When considering surgical procedures, it is important to at least have a patient with a normal TPR, which means a temperature that's within normal range, a respiratory rate that is somewhat normal, even if the patient is panting, making sure they're not exerting more or a higher respiratory effort. Mucous membranes are nice and pink. Capillary refill times within 2 seconds, and they are not running a fever. The veterinarian or the technician should sculpt the heart and lungs just to make sure they don't hear any abnormalities, crackles in the lungs, sculpt all the chambers of the heart just to make sure that there is no murmurs or anything that sounds abnormal before the patient is anesthetized or sedated or anesthetized for a surgical procedure. As far as standards, as far as my practice is concerned, and is consistent with a lot of the practices where I worked before, pre-anesthetic blood work does consist of a blood chemistry, where there's a smaller Chem 10 panel that at least checks for BU and creatinine, alkaline phosphatase, and I think ALT, or has a larger chemistry, which we typically do for patients that are over the age of 7, and that will check calcium, and also check the pancreatic enzyme levels. Also included with that panel are your electrolytes. We will run what is called SDMA on our older patients. That checks for early changes with the BU and creatinine or kidney changes prior to them being detected on a regular blood chemistry. And then a CBC comes with all of our pre-surgical panels. In a pinch, in times where we've worked with spay neuter clinics, we have ran a PCV and a smaller blood chemistry just to make sure we have some baseline blood work. But it is recommended to get some sort of diagnostics now. Of course, mass removals and things like that, especially on geriatric patients, we like to do radiographs in addition to our lab work. So let's say it's a mass that we think might be something that could be malignant and potentially metastasize to the chest. We would do a 3V chest radiographs. Depending on the type of surgery, abdominal explorer, we would do radiographs of that specific area. Like the TPLO that we did, not TPLO, the lateral stabilization that we did today, we took 2-view left knee radiographs just to ensure that we are seeing exactly what the doctor is feeling, and that there is joint effusion, can be appreciated on radiographs and things like that. But that's typically tests are required as far as my practice is concerned. But in a pinch, if it's an emergency, the patient is healthy, and you need to sedate them to go ahead and clean a wound or address something, or even in spay neuter clinics, a solid TPR with a clear auscultation of the heart and lungs is what's necessary. Thank you. So I am actively prepping for surgery. We've got a cranial cruciate ligament tear that we're going to do a lateral stabilization on today, and we have a neuter on a 9-month-old Labrador Beagle mix. For pre-op medications, I'm going to give this dog a little bit of Cerenia to help with the nausea, because as pre-meds I'm going to give him hydromorphone and acepromazine. The dosing of the hydromorphone and acepromazine are going to be used to kind of help reduce stress and pain during induction in the surgical procedure. The hydromorphone dose is going to last for 8 hours. So I'm going to give that about half an hour prior to induction. And then once I've gone ahead and given him his alfaxin dose to induce him and he's been intubated, I'm going to go ahead and give him a dose of carprofen. I'm going to give him the 12-hour dose of Rimadyl that will sustain him through the rest of the day today. So I'll have hydromorphone on board for 8 hours and an anti or an NSAID on board for 12 hours. So the idea is having these medications on board will help control any pain that he may feel during the procedure, and then to kind of help him wake up systemically more comfortable. He might be dysphoric because of the withdrawal from the isoflurane, but he will not be in pain. And then for the owners to take over the pain prescription regimen when they get home, either starting tonight or tomorrow morning with the NSAIDs. And it's a neuter, so gabapentin if necessary. Most of our neuters do go home with gabapentin at least for 7 days. So with NSAIDs and pain medications, that is how we manage pain both intra-op and then post-operatively when they go home. I'm going to pre-med him here shortly after I give him a Cerenia. And with the cranial cruciate ligament repair, since there is not too much infiltration into the bone, not like doing a TPLO where you're actually using the semicircular saw to adjust the angle of the bone, he will get the same prescription injectable medication regimen as the neuter, in hopes that that will also help alleviate any intra-op and post-operative pain, and definitely going home with gabapentin and probably some trazodone to help with anxiety as well as those NSAIDs based on blood work. So going over leak testing your machine, knowing how the anesthetic machine system works. So here's my oxygen level. So knowing how to turn your oxygen on and off, that is fed through an oxygen tank, which usually has a tube that connects to the back of your machine. Once the oxygen is delivered to the machine, it goes into your isoflurane or sevoflurane tank. This will vaporize the liquid and turn it into a gas. The gas is then fed to the inspiratory line. Your patient breathes that, and then when it breathes out, and these closed systems, it's just one tube, it breathes out through the second airway or air tube, going back into the expiratory. And the waste goes through the soda lime canister, and this absorbs some of the carbon dioxide and then some of the isoflurane, and then the CO2 or any other gas is pulled out through the active scavenge and goes to your active scavenge to your active scavenge system. If you don't have active scavenge, it goes to an F-air canister. So we're going to leak test this machine. The first thing you need to do is make sure, I just leak tested it. Make sure the pop-off valve is completely closed, because this system is designed, especially with the active scavenge, to go ahead and pull the excess carbon dioxide that is expirated during a regular breath. So after my pop-off valve is closed, I'm going to go ahead and cover the inspiratory and expiratory hole, expiration hole. That way there is no air or no gas leaking. I'm going to go ahead and turn my oxygen on, and I'm turning it up all the way. You want it to be at pressure in your rebreathing bag. So once that pressure is established and you check it at about 20 psi, you can go ahead and turn it off. Now, holding, the oxygen is off and it's holding pressure at about 20 psi. Now, once my pressure is holding, I can go ahead and squeeze my rebreathing bag, and the pressure should not drop either. So right now it is holding at about 30 and it is not going down. You can see the pressure gauge in the back. So I'll go ahead and let a little air out. You can see when I add more pressure to the bag that no air is escaping. So that means that there are no identifiable or substantial leaks within my system. So I would say that this anesthesia machine is good for surgery. All right, thank you. What's up?
I'm back and I'm better.
Okay, good. Right there, 30. And it's not moving, it's not going down. So it is holding good pressure. You go ahead and open up the pop-off valve. And that's going to release. Go ahead and flush my bag. Put this back and let's get ready for surgery. All right, so I'm going to prepare this patient for his neuter and trying to figure out which endotracheal tube to use. So because of his size, I'm going to choose between a 10 and a 9 millimeter Elizabethan tube. Endotracheal tube. And so I'm going to measure the space in between his nostrils. Looks like the 9 is a bit too small, but I will keep it on hand. And just in case he has any narrowing of his trachea and it's difficult, but because this is evenly spaced between his two nostrils, we're going to go with the 10. So we've got our ECG on, and there is our entitled CO2 down there.
There's two 305s.
So
That she must have been what I was looking at.
the cabinet right
Oh, or it's a
Comes
group
all the
that's
way here.
together. Yeah.
All right, and there is the CO2, entitled CO2 right there. It is an important task as the surgical nurse or the surgical technician to help maintain the sterile field during all surgical procedures. This includes making sure that sterility is not breached, that any instruments that the doctor requires that are not in your general surgery pack are handled or given to the doctor in an appropriate sterile manner, making sure that from the beginning to the end of the procedure that sterility is maintained. This means minimum contact from any personnel who are not sterile. People should not be going in and out of the OR operating room. Doors should be closed at all times. Anything below the waist is considered non-sterile, even if the surgeon is gowned. So anything below the surgery table, below your waist, is not considered sterile. So if an instrument is dropped, it's gone. Happened today. Don't pick it up, try to hand it back to the surgeon. It is gone, it's considered non-sterile. Get another instrument, or if the doctor doesn't need it, just keep it moving. Making sure that you have your face protected. If you have hair, mine is growing back right now, that is covered. Keep your beard neatly trimmed. Make sure there's no hair. Some people have to wear the cover. Most of the time my mask covers my beard, but some people do need extra protection, especially when their beards are long. Making sure anybody involved in the actual surgical procedure, mask, cap, sterile gloves, and gown and booties, all those proper protective equipment to keep you sterile are in place. And just watching, I know our OR was particularly small, so moving around the table, moving around the operating table, just being careful not to touch the patient drape. Some of our patients are draped twice. So for orthopedic procedures, for instance, we'll take sterile quarter drapes and quarter drape the specific surgical area. And then we will take a patient drape that's not fenestrated. The surgeon will normally cut their hole and then cover the entire patient. Some drapes do cover the entire patient and the Mayo stand, but all of that stuff is usually EO sterilized, which means it is sterile. And once it is applied, it is not touched by anybody who is not draped in for surgery. It is very important. If sterility is breached, then start over. I have had an orthopedic procedure where sterility was breached, and scrap the entire Mayo stand. They take everything off, uncover the patient, start over, because it's important, especially if you're dealing with bone or the abdominal cavity or working the chest, that we are not inviting any microbes or bacteria into the patient's body, because that can prolong healing. It can have adverse effects on the procedure that we're trying to accomplish, and sometimes it can lead to a critical situation. So important rules to follow as far as sterility is concerned, and of course keep in contact with your doctor. That way you guys are talking to each other and you understand what the expectations are and what the expectations are of the people that are around you. I know I communicate effectively, but occasionally I do need my doctor to help me, especially if there are other people scrubbing in or there's anybody else helping me assist the doctor. All right, thank you. All right, setting up the OR is a relatively simple procedure that should be done at the beginning of any surgery day. For some clinics that's every day, some clinics have specific days they do surgery. So a few things you need to do or you need to get are going to be your sterile surgery pack, sterile surgery gown, and sterile surgical gloves for your surgeon. If you have multiple surgeons, you have to get more than one. We typically have one surgeon at a time. So the first thing I'm going to grab is the particular surgeon's size gloves. We have a variety of different sizes from 5.5 to 7.5. The doctor will be doing surgery Friday. I have a 7.5. While I'm here, I'm going to grab a sterile surgical gown. Alright, I'm not going to open those yet because it's not surgery time. You don't want to leave them open to the environment. And I'm also going to grab a general surgery pack. So this is a small general surgery pack we can use for small dog neuters and also for cat spades. So I'm going to grab these things first, and I'm going to set them up. So I'm going to take my general surgery pack, and I'm going to put it here on the Mayo stand. The outside drape will act as my Mayo stand cover. There are Mayo stand covers designed to go directly over the Mayo stand, but we have a large, when you have a large outside drape, that can also act as a Mayo stand cover. I'm going to take my surgical gown and my gloves and put them over here. And you put them in order because your surgeon will gown up after they've scrubbed, where they can dry their hands and then they put on their sterile surgical gloves. The other thing that I will put over here with my general surgery pack is I will grab a 10 blade from the Breezeway. In the Breezeway, we also have our extra isoflurane if necessary, and I've got the shoe covers, bonnets, and I've also got my surgical masks all here. So when the surgeon comes in, he'll already have his mask and his cap on and come in and get warmed up. So I'll leave my 10 blade over here. I'm going to open up my primary layer for the outer pack drape that act as my Mayo stand cover. I will also drop my 10 blade. The operating room table is also set up ahead of time. It's pretty simple. So we have a towel or a layer that goes down under the patient. And it usually protects them from the cold of the stainless steel. Then we have our heating pad. So some tables are heated and you don't need this pad, just a cover or something to protect the patient from being directly on the table. So to keep our patient from being directly on a heating pad, we're going to cover this up. That way they're still receiving external heat, but it's not touching the patient directly. So our sharps container down here, and this is the heating unit for the water blanket. And that will be cut on the morning of surgery to help bring it to optimal temperature. That way it will be good to go or ready to go once we begin surgery. That way, if it's an abdominal procedure, we do not lose a lot of the internal heat to the external environment, and will help keep that homeostatic balance. It is an important task as the surgical nurse or the surgical technician to help maintain the sterile field during all surgical procedures. This includes making sure that sterility is not breached, that any instruments that the doctor requires that are not in your general surgery pack are handled or given to the doctor in an appropriate sterile manner, making sure that from the beginning to the end of the procedure that sterility is maintained. This means minimum contact from any personnel who are not sterile. People should not be going in and out of the OR operating room. Doors should be closed at all times. Anything below the waist is considered non-sterile, even if the surgeon is gowned. So anything below the surgery table, below your waist, is not considered sterile. So if an instrument is dropped, it's gone. Happened today. Don't pick it up and try to hand it back to the surgeon. It is gone. It's considered non-sterile. Get another instrument, or if the doctor doesn't need it, just keep it moving. Making sure that you have your face protected. If you have hair, mine is growing back right now, that is covered. Keep your beard neatly trimmed. Make sure there's no hair. Some people have to wear the cover. Most of the time my mask covers my beard, but some people do need extra protection, especially when their beards are long. Making sure anybody involved in the actual surgical procedure, mask, cap, sterile gloves, and gown and booties, all those proper protective equipment to keep you sterile are in place. And just watching, I know our OR is particularly small, so moving around the table, moving around the operating table, just being careful not to touch the patient drape. Some of our patients are draped twice. So for orthopedic procedures, for instance, we'll take sterile quarter drapes and quarter drape the specific surgical area. And then we will take a patient drape that's not fenestrated. Surgeon will normally cut their hole and then cover the entire patient. Some drapes do cover the entire patient and the Mayo stand, but all of that stuff is usually EO sterilized, which means it is sterile. And once it is applied, it is not touched by anybody who is not draped in for surgery. It is very important. If sterility is breached, then start over. I have had an orthopedic procedure where sterility was breached, and scrap the entire Mayo stand. They take everything off, uncover the patient, start over, because it's important, especially if you're dealing with bone or the abdominal cavity or working the chest, that we are not inviting any microbes or bacteria into the patient's body, because that can prolong healing. It can have adverse effects on the procedure that we're trying to accomplish, and sometimes it can lead to a critical situation. So important rules to follow as far as sterility is concerned, and of course keep in contact with your doctor. That way you guys are talking to each other and you understand what the expectations are and what the expectations are of the people that are around you. I know I communicate effectively, but occasionally I do need my doctor to help me, especially if there are other people scrubbing in or there's anybody else helping me assist the doctor. All right, thank you. All right, preparing for a cat neuter. So I've got my alcohol in scrub, got my pulse oximeter, got sterile gloves for the doctor, a 10 blade, got a mosquito hemostat, got some gauze, and then we've got our antecedent drawn out for our patient. So now I'm going to get the cat out and prep and scrub, sterile lube, thank you. I have to call Dr. Wilson 1 second. It's in. Eyes are lubed. Pulse ox on an ear. And then we'll go ahead and clean and prep. I'll give him his Onsior now. That's done. And since this is an open castration, we are not going to intubate him. Pre-anesthetic blood work was performed just to make sure he is a good surgical candidate. So he got a Chem 10 and a CBC. Everything, BUN, creatinine, are all within normal limits. Red blood cell and white blood cell levels are completely normal. Hey, our routine cat spay, or neuter, sorry, turned out to be bilaterally cryptorchid. So right now, there's the first testicle.
I need some suture.
What?
Actually, you know what? Let me see if I'm just gonna tie it. I might just. Let's see.
Do you want some ot or like some 3-0?
Let me see. Maybe I'll just. Three. Did you get the cephaloxime?
I'm about to.
So it's 21,
21,
200s,
200,
1.5 once daily.
Okay.
And then she wants Gen 1 spray too.
200 what?
Gen 1 spray.
That might be a refill. We've done that one already. Yep. So we're doing 1.5 once a day for 2 weeks.
Twice daily for 14 days.
Mm-hmm.
Okay.
Yep. There's no skin glue blood.
Alright. Good.
No, we're not going to do no video. We're going to do blood donation.
Hold on a second. Let me do one quick little closure here.
Go for it.
Look at the work better.
She agreed to everything.
Okay, so let's turn that on. So Jess is going to draw the blood here in a second. You guys get a pen for me.
Okay. This was the packet, right?
No, the pack's over here. Oh, that's for the gown.
Then I have the stuff over here for this last pack, so I was just thinking.
Is this the only gown we have? Is this the only gown we have?
Yes,
Okay.
that's why I was
So
cleaning.
you can clean this one.
Oh, yeah.
I mean, I can wrap it again.
I know, we got 2 surgeries tomorrow, though.
Yeah.
So we do. What do we have on?
Yeah, I think we got 2 tomorrow. We have 2. Okay.
I thought we had 2.
I thought we had 2, but maybe that's next Tuesday. I told him to go ahead and put 2 on because one of them was a neuter.
He doesn't need a heating pad, right?
Heat bag?
He may.
I don't think
Tip
so.
is 1026.
Okay. Give me 1 second. You have the ultrasound. We turn the ultrasound machine
I
on.
was cleaning the area.
Okay.
We need the trough.
Yes.
And here he is post-op. Completely awake.
He died.
Nah, he did great. I'm not coming in and rub your belly. All right, cleaning the OR, something that has to be done after the end of your surgical day. Different from flipping the OR in between procedures. So getting everything off, wiping everything down, sweeping or vacuuming if you have a central vac, and then mopping, and then shutting the doors and closing the OR down for the day. The idea is the OR is to remain closed just to ensure that there's nothing coming in. And that way it is just the way you left it when you come in the next day for procedures. So as you're doing your sterile procedure, it is important to clean as you go. Anything that is wrapped, anything that is discarded into the floor, making sure you get these things up. That way the cleaning process does not take as long towards the end of the day or the end of your surgical day. The average surgeons ran a little longer than they normally do, so you didn't get a chance to start cleaning the OR until the end of business today. So taking care to remove all of my drapes, my towels, and treating everything with a bit of care and respect. That way nothing gets damaged or it's unusable for the next day. So I'm taking off my towels, I'm taking off my external heating device. And all of my wraps and anything in here that needs to be discarded. And then next we're going to shut down the anesthesia cart and start to wipe and clean that, and we'll clean our operating table as well. Alright, next thing I'm going to do, now that I've gotten all of my paper trash out, is go ahead and spray down my OR table and my nail stand with a Parvisol. I'm going to let that sit while I clean my anesthesia cart. Alright, so to maintain your machine, I'm going to go ahead and turn this all the way down. So I'm going to take off my rebreathing tube. And take off my rebreathing bag. The ones that we use today, I'm going to go back to where they are stored. Every OR is different, so I'm not quite sure where you store yours, but make sure you're putting that away. Alright, next I'm going to wipe down our anesthesia cart. So the first thing I'm going to clean, you can use leftover gauze. At the end of the day, you can use paper towels. And make sure that you clean your electrocardiogram leads. So I'm going to bring the anesthesia cart over here. It's easier for me to clean. Using alcohol to clean all of my leads. So you want to get in between the cracks and crevices of your leads, making sure that you're getting them clean. Occasionally, depending on the procedure, there will be stuck on blood. Luckily, none of our procedures were extremely bloody or messy today. And one thing that gets neglected, depending on the clinic and who is cleaning, make sure you actually clean the line to the leads. Occasionally you will get blood stuck on here, and it will harden, and eventually that will mess up your leads. Or they'll start to stick and get really gross. Make sure you wipe this all the way off. And then take care to roll this up so that it's stored securely, but not enough to where you are bending the metal inside the cords. So you can actually destroy the metals inside of these cords, and you'll no longer be able to get an ECG signal. So if you're not getting an electrical signal through your cord, it's not going to do you any good for your patient. So I've seen several people wrap this up very tight, but trust me, it's not going anywhere. Just a little blood there. Make sure they're nice and clean, and then put them away. So on my cart, I go into these different places where I can hook my leads when they're not in use. That way they're not on the ground, but they do not need to be hung up anywhere special. All of my blood pressure cuffs are going to go in my bin, so I keep all of my cuffs together. All my different sizes in there. My pulse ox, which has not been working, I used the external pulse ox this week. It's still clean, so just keep an eye on that. But if you have a normal functioning anesthesia cart, make sure you wipe that off and wipe the probes where they come into contact with the mucous membrane or whatever surface that you attach them on. And wipe off the blood pressure tube. And ours came with these handy Velcros. So it helps me to wrap it up and keep it in one place without having to roll it over on itself. So I'm gonna roll that up. And then my esophageal thermometer has to be cleaned. Roll this up. Take it there. And then my esophageal thermometer. Rag. It does not go that far into the esophagus, but clean the whole thing. Again, take care to roll it up loosely and not tight coils, because again, you can throw off the sensor. And for this one, I will wrap once and set it there. So when you're finished, your anesthesia cart should look like this. Everything where it should be. Next, we're going to sweep and mop the OR. I'm going to wipe off my OR table and the mail stand, and then we're going to sweep and mop the OR. All right, so we have a dry mop that we use specifically for surgery. So there were not a lot of hairy dogs, but I'm going to run a dry mop over here anyway, because when the OR doors open and close, occasionally you bring in or track in bacteria or dust. So I'm going to run this all over the OR floor. You can also pick up any leftover suture that's fallen off, like there's some ortho fiber and some hair. So I'm going to make sure I mop all this up before, sweep all this up. I guess mop from using the dry mop. And then get that before I'm pushing my pile outside of the OR. Then go around again. And then I need bird seed. I need to wrap up the electric artery plate. So in there?
Because I'm still like on standby and Jasmine had asked Jen if she heard anything from Nakaya. She said no, not anything yet.
Unless you're coming, not.
And we don't know. She told me and Zeke she was coming today and tomorrow, so
Okay. Then I'll trust her.
I believe her.
Yes. Now every OR should have a specific mop that's used just for the operating room floor. So I'm gonna go grab the little mop that we use for this floor and do a quick mop. All right, and I've got my mop specific for surgery. So I'm gonna go ahead. Oh Lord. You looking for Bree? Yeah. Who's on dress got cookies?
My cousin.
No.
So if you want some, let me know. I'll get y'all whatever y'all want.
I will let you know.
For sure.
Because my niece has graduated from the Girl Scouts. And her sister is not doing it. She's going across. You're finished. Close the doors to your OR, and you're done for today. Thank you. So maintaining your autoclave is essential for it to continue to work properly. That does include cleaning your autoclave and also making sure that there is enough distilled water in the tank to run every single cycle. Most autoclaves have a fill line, so the distilled water should be at or close to the fill line before every single run. That keeps it from drying out. So if the autoclave gets too dry, if there's not enough distilled water to help maintain the autoclave, sometimes your packs may burn. To clean it, you can use either the autoclave powder or you can use the OmniClean. I have to start on the second bottle of OmniClean the next time I clean this. So to clean your autoclave, and I just ran it, so it's hot, I'm probably not going to do it right now, we can come back to that later. You want to make sure that you open up the reservoir and you let all of the used or burnt or debris distilled water out. Go ahead and flush it. You can flush it with sink water just to get everything out. Then you want to fill it with distilled water and OmniClean. Run a cycle. After that cycle, you want to go ahead and flush it a few more times and run one more cycle with the new distilled water. After that, the autoclave is clean. You should also take out any of the internal elements, whether there is a cage or a tray where you put your sterile instruments, and if there is a table or something that you put your instruments on or put the tray on top of that keeps the packages from getting saturated. You should also clean the hose or the tip that goes into the autoclave that feeds the distilled water. Sometimes that will become rusted and be filled with debris. Sometimes it will be covered up by some particles from the outer pack, especially if you're using a fabric wrap. Some of the lint and stuff can form there and get stuck there. So make sure you scrub all that clean. Also scrub the inside of the autoclave clean without causing a lot of abrasions to the metal surfaces. They do make powders that you can put to help clean that, but at least once a month it should be drained, cleaned, flushed, and then set to go for another 30 days. The only option is if you actually go to the gym at 4 weeks and do not do surgery, it's not being used. But we can show that later.